All right, so now it's time to talk about the appendicular skeleton. Now, I know that I did not give y'all anywhere near enough time to learn everything in the axial skeleton. That was not necessarily part of the plan, but that's just kind of, we do have to move on a little bit. Hopefully between last time and this time, you've at least had a chance to look at the models for the things you wanted to look at. And you will have more time today. Now, to give us more time today, did y'all do like I did last time and ask y'all to look at all the appendicular skeleton stuff before class? I'll take that as a no. Okay, I'll take that as a no. All right, so because of that, I will walk through this at least a little bit more slowly. All right, now remember, we do take the skeleton, we divide it into axial and appendicular. Axial is the skull, the vertebral column, and the thoracic cage. The appendicular skeleton is everything else. So the appendicular skeleton basically means that we're going to be talking about the bones of the limbs and their girdles. That's to say that the bones that are going to allow us to attach them to the body trunk, okay? Now, I also want to remind you that we have lots of bone markings. For every bone that we look at in here, you're probably going to see anywhere from 2 to 5 markings on that bone that you will need to remember. So I will kind of remind you of table 8.1 is your friend. If you learn the definition of each and every one of these bone markings, it will make identifying them that much easier, because usually they're going to be named off of what attaches there, whether it's the muscle or even sometimes just the name of the bone and stuff like that. So learning the names of these bone markings will make your life a lot easier. Now, upper and lower limbs are going to be very, very different, okay? One, your lower limbs have to hold your weight, okay? That is a big deal. My hands do not have to carry my 200-pound ass all over the place. Instead, they get to do things like pick up remote controls and break eggs and stuff like that. However, we don't need the same amount of force to pick up an egg, or by need, it would be bad if we use the same amount of force to pick up an egg as we do to kick a soccer ball. Those are two very different sort of circumstances. We need very different types of muscles attached to those. We also need a lot more finesse in places like our hands because of that. We don't want to break that egg that we're trying to eat. Now, because of that, our lower legs do not have nearly as much flexibility. So we lose a little bit of mobility in order to gain extra stability, that's to say extra strength. Your arms are going to be far, far lighter than your legs because they don't have to carry you around. That's not to say that you can't train them to do so, but putting that amount of stress and stuff on them is going to necessitate both getting extra muscle strength, but also getting extra strength in the bones to allow them to be able to do that sort of stuff. Your legs have less mobility in the joints. However, they are far, far, far more stable, okay? It's also very important that we be able to support that weight so that if we do get injured, that we can still at least move and stuff like that, okay? All right, now the pectoral girdle. This is very, very light. These are light bones, like the clavicle is this long and it's not too much bigger around than something like, say, a pencil, okay? However, it is incredibly, incredibly important, okay? Together, the clavicle and the scapula are going to support the weight of the upper limbs. They're basically going to take all that weight and transmit that weight to the body trunk. They're also going to act as braces with one another. By doing this, they will kind of hold each other in place, and by holding each other in place, they're going to allow the bones of the upper arm to move on their own. Okay, so this way we can move the humerus without moving the clavicle and the scapula, because the clavicle and scapula are going to be braced against one another, holding each other in place. Okay, so that the scapula in particular isn't sliding up and down. Because of that, though, if you have an injury to something like your clavicle, you no longer have it acting as a brace, or at least it has a hard time doing that. So every time you would go to lift your arm to do something, even as simple as, say, picking up a pencil, that is going to cause excruciating pain because you're now going to be putting pressure against the thing that is broken. That's why if you've ever seen someone with a broken clavicle, their arm needs to be immobilized. That way they're not kind of putting additional stress on that broken bone while it is healing, okay? Now, your clavicle, we're gonna talk about it here in a second. So you are gonna see some kind of divots for places for muscle attachment and stuff like that, as well as some divots for articulation. All right, the first of these is your clavicle. Like I said, it is fairly small. We have a big blunt end. The blunt end is going to be medial, so it's going to face your sternum. This is why we're also going to call it the sternal end. The other one is going to face the acromion process, which is on the clavicle. Thus, it's going to be the acromial end. And we're going to have this nice kind of anterior bend, okay, where the frontmost portion of it is going to be anterior, but then we're going to have this nice curve, kind of the curve faces the posterior spot. That's basically to give us a wider opening for all of the nerves and blood vessels and stuff like that, and muscles. They're going to be passing from your head down to your torso, okay? Now, if you feel your clavicle, you'll also notice that it is basically nice and smooth up until you get to the end or up until you get to either end. That's the only place where you really feel anything that's not perfectly smooth. However, if you look at the inferior surface of one of these, so if you take an inferior view, notice that you see this big ridge right here, and you have some rough spots. So whenever you're looking at one of these clavicles and you're trying to figure out if you have a superior view or an inferior view, you're going to be looking for those ridges. The ridges and stuff tell you that you are looking at the inferior side, okay? Now, the scapula. The scapula is going to have some divots in it. We have some divots on the front and we have some divots on the back, okay? These divots or these fossae are going to be for muscle attachment. In fact, the muscles that attach to these are going to be muscles of your rotator cuff, okay? They're just going to kind of live in these spots. So one of these, or on the posterior side, we have this big thing called the spine. You can actually feel this. So if I told you to reach back and touch your scapula, you would probably first touch the spine. That's going to be the most the easiest thing to notice whenever you're trying to find your scapulae is actually going to be this big bony ridge. So this big bony ridge has to point posteriorly, okay? And you can actually, like I said, feel this whenever you're feeling your scapulae. We have muscles above it and muscles below that spine, okay? Then we go out here to this big flat protrusion, so this big flat process. This is the acromion. Then we have the other one that's, when viewed from the front, kind of looks kind of curved like a bird's beak. This is going to be your coracoid process. So these are the two most important processes on the scapula. And then we have this big divot right here, which is the glenoid cavity. The glenoid cavity here is going to articulate with the bones of the upper arm. Particularly, it's going to articulate with the bone of the humerus, okay? So, or the head of the humerus. So here we have the humerus. The head, like I said, articulates with the glenoid cavity and the scapula. The motion of the scapula, or the head of the scapula, or the head of the humerus inside the scapula is incredibly mobile, okay? We can do all kinds of crazy stuff with our shoulders. We have this massive range of motion. However, that massive range of motion comes at a cost. Anytime you have a really, really big range of motion, guess what you also do not have? Stability. It is actually quite easy to dislocate shoulders. Ask me how I know. I've dislocated both of these. Is it fun? No. Would I recommend it? Absolutely not. If you happen to be around someone that dislocates their arm, should you put it back into socket for them? No, you should not. Okay. However, they are quite easily dislocated, okay, because this joint is very, very shallow. Very, very shallow means lots of mobility, but we do not have a whole lot in the way of stability, okay? Now we have a little groove right here running through this for muscle and nerves, but then we're going to run down to only the next big structure that we see on the humerus is actually going to be this big thing right here. This is going to be called the deltoid tuberosity. So a tuberosity, remember, is a roughened projection for muscle attachment. Okay, so in this case, we're going to have a roughened attachment for, or site for muscle attachment of the deltoid. Okay, that's the main muscle of our shoulder here. Okay, so the muscle of your shoulder is going to attach to that deltoid tuberosity, which is on the outside. That's why the deltoid muscle is really, really, really good at elevating your arm. Okay, basically it gets held in place by your clavicle and scapula, and then allows you to kind of pull your upper arm up. As we move back down, or continue moving distal, we find these two different articular surfaces. We have one articular surface that looks like a spool that we're going to call the trochlea, and then we're going to have the other one that looks like a marble called the capitulum. Now, these are going to be at your elbow. Now, which direction does your elbow bend? Towards the front, right? It bends anteriorly, which means we're going to have our articular surface be primarily on the anterior surface of our arms. So if we look at the posterior side of the humerus, notice that the capitulum goes away. We can't see the capitulum anymore. So the presence of the capitulum is going to tell us that we are looking at the anterior surface of the bone, okay? So the presence of the capitulum is going to tell us that we're looking at the anterior surface of the bone. Now, I do want to draw your attention to a couple of other things. We have a little divot above each of these articular surfaces. We have two little fossas right here. One, so the one above the capitulum, is called the radial fossa. Anyone want to guess what's going to fit right there? Probably something with the word radia in it, right? So this is actually going to be the fossa for the head of the radius. So as we bend our arm up, that there's a little cavity in that bone where the head of the radius can fit, giving us a wider range of motion. Now, then we also have a fossa right here called the coronoid fossa. That's going to be for the coronoid process of our ulna. So our ulna is going to fit on the trochlea. The head of the radius is going to sit on the capitulum. So the radius is always, or is going to be lateral, and the ulna is going to be medial. So the ulna is medial, the radius is lateral. Notice I did not say on the right or on the left. The ulna is medial, the radius is lateral, okay? Now, we also have this little cavity right back here that we call the olecranon fossa, okay? Now, the olecranon fossa is basically this divot for the olecranon process on the ulna, which is gonna have this kind of U shape, okay? Now, we also have a little groove right here running alongside our medial epicondyle. Because we have a little bit of a groove right here, our nerve, or our ulnar nerve that goes to the ulna, which makes sense, is going to pass right through this little gap right here, and it's thus going to be exposed right there, which means if you happen to bonk your elbow in that particular little soft spot, you're going to feel this twinge run through that nerve. We call that our funny bone because we have some nerve exposed there. When you hit the side of it, it just sends that little pulse through all of those nerves, so things can feel a little wonky. So that's where we get the funny bone. This is also called the humerus, which there we go. All right. All right, now radius and ulna. So here we have an anterior view, here we have a posterior view. These are both of the right bone. So we're not looking at any lefts right here, okay? So here we have the coronoid process, or sorry, coronoid process is right here, and then we have the olecranon or the olecranon process here, pointing more posteriorly. If you look at it from the side, it's gonna make a little bit of a U shape, okay? So U for ulna, and it's gonna have this U shape on the end. Now we also have a little divot in the side of the ulna for the head of the radius. This is going to allow the head of the radius to spin, okay? You may not realize what I'm talking about yet, but I'll show you in just a second, okay? And I may even be able to show you on one of our models over here, okay? We also have a big bump right here near the head of the radius, or just distal to the head of the radius, called the radial tuberosity. This is actually the site of attachment for your biceps brachii, okay? So where your biceps attach is gonna be right there on that radial tuberosity. As your bones spin, you'll actually be able to track where that radial tuberosity is going by looking at your biceps muscle and noticing that your biceps muscle actually has to move and extend a little bit as that moves away from you. So if you kind of flex your arms and then pronate and supinate your hands and say kind of flip your hands up and down, you'll be able to see that your bicep muscle is changing shape a little bit as it's following that radial tuberosity. The ulna will stay in place during that whole process. All right, so if you take your hands and you put them on the table with your palms facing up, your hands are in what is an anatomical position. This is also supine. Okay, so they're on their back. Okay, because of that, the two bones of the forearm are going to be running in parallel. Okay, so we're going to have one bone that's going to go basically from this medial line down to kind of the pinky side of your hand. Then we're going to have another bone going from the lateral side all the way down to the base of your thumb. Okay, where the bones are in parallel, where we have the ulna that is medial and we have the radius that is lateral. But as you pronate your hand, so that's to say, as you kind of twist your hand to face palm down, when you do that, the head of the radius is going to spin. Oh, snap. Did not anticipate that. How am I going to get this over this cord? Okay. All right. So as we pronate our hand, we're going to see this bone twist. Okay. So the head of the radius is flat and it's sitting up against the surface of essentially that marble that is the capitulum. As it's sitting there, whenever you go to pronate your hand, you go to flip your thumb over, the head of the radius is going to spin on the surface of that marble, and it's going to allow those two bones to kind of cross over. Okay. So now if you look at the bones, we can see that the bones of the forearm are now completely crossed over. Where at the elbow, so at our elbow, the ulna and radius are still, so ulna is medial, radius is still lateral. But at our hand, the radius is now medial and the ulna would be lateral because the bones are basically crossing over and making an X. Okay. So that is only happening when our hands are pronated. When we go to supinate, we're going to see spinning right here on the head of the radius as we bring the bones back to parallel. Does that make sense? Okay. Go away, Steve. Pretty sure he's looking at me. It's fine. All right. And we'll talk more about those motions and the muscles and stuff that cause those. All right. Then we get into the bones of the hand. Okay. All right. Once we get down towards the digits, once again, we have the radius and ulna. As you can probably realize, I really like interactions between the bones, which means you need to know the names of the structures, at the very least, the names of the bones that interact where. Okay. Now, once we get into the hand, we have three major divisions. We have the bones of the wrist. So the bones of the wrist are going to be the carpals. Then we have the bones of the hand. So the bones of, they're kind of the fleshy bit of your hand. These are going to be your metacarpals. And then finally, we get to the bones of the digits. The bones of the digits are the phalanges. So bones of the digits are phalanges. Bones of the hand are the metacarpals, and the bones of the wrist are going to be the carpals. Good way of remembering this would be like carpal tunnel syndrome. Okay. Now, you'll notice that all of these carpals are named. I am not a demon, and thus I'm not going to make you memorize all of them. However, I do want you to know two. The two that I want you to know are scaphoid and lunate. That's because these are the two bones of the wrist that are actually going to articulate with the two bones of the forearm. Okay. So the radius articulates with the scaphoid. So the scaphoid is the one that's closest to the thumb. So if we kind of track it, that is basically the base of the wrist on the thumb side. So the radius articulates with the scaphoid. The ulna articulates with the lunate. Ulna with the lunate. So U to L in ulna, U to L for ulna to lunate, Q, R, S, radius to scaphoid. Make sense? Okay, that's probably the easiest way that at least I have thought of to remember that one. All right, then we get into the bones of the legs. In our bones of the legs, we have three large bones that are all fused together. So we call this the os coxa, or the hip bone, or the pelvic bone. Okay. Together, though, we have three bones. We have the ilium, the ischium, and the pubis, where the ilium is going to be the largest portion of the three bones. And then we have the pubic bone, which is going to be anterior, and then the ischial bone, which will be posterior. Okay. So ilium, pubis, ischium. Everybody good? Now, these are very important for supporting our pelvic organs. So we have to have a big, essentially kind of smooth surface on the inside so that we don't have pokey bits facing soft, squishy stuff. So supporting all those pelvic organs, helping hold them in place by also being attachment sites for very, very strong muscles that move us on the outside, but also very, very strong muscles on the insides of these, which are once again helping to support those pelvic organs. If you've ever heard of Kegel exercises and stuff like that, that is actually muscles to support your pelvic floor. Okay, so that's basically going to be muscles that are on the inside of your coxal bones, while your external muscles are going to be the ones that are actually allowing us to move your legs and move your hips and stuff like that. So because these, though, are supporting a whole bunch of weight and they're holding on to the strongest muscle groups we have, like your gluteus maximus muscles, your hamstrings, your quadriceps, things that cause you to move, as well as all the stress that all of that stuff requires, these muscles have to be large. They have to be heavy, because that is a massive amount of force and a massive amount of torque that are being placed on these at any given time. So they have to be very, very heavy to be able to deal with that. Okay. Now, we call this big ridge right here at the top of the ilium, we call this the iliac crest. Well, here we have a roughened projection for muscle attachment. What was our word for roughened projection for muscle attachment? Tuberosity, right? So here we have a tuberosity. That tuberosity is on the ischial bone, so it's called the ischial tuberosity. Okay, this is a spine on the ischium, so we call this the ischial spine, and so on and so on and so on. Okay, we also have this big hole right here. This big hole right here we're going to call the obturator foramen. And then we have this bridge basically that is between the pubic bone and the ischial bone. The word for bridge here is ramus. Okay, so this would be our ischial ramus and then pelvic ramus. Okay, or pubic ramus rather. And then all that connects around the whole point, or one of the whole points, which is connecting our legs to this bone. That site here is going to be called the acetabulum. That is a very, very deep, heavy divot right here, which is going to support the head of the femur. Now, we're also going to have on the medial side of this bone, this kind of ear-shaped structure right here that we're going to call the auricular surface. So it kind of looks like an ear, thus auricle. Okay. This is actually where we're going to connect it to the sacrum. Okay. Now, the hips between male bones and female bones are actually going to be a little different. So male pelvises and female pelvises are going to be a little different. However, this is not a completely dimorphic thing. There is some sexual dimorphism here where male-like bones are going to look more like these, female bones are going to look more like this, but it's not completely cut and dry with nothing in between. There are going to be lots of intergradations, and some of these may actually be somewhat difficult to tell apart. Okay. However, in general, female hips are going to be wider at the top, have a shallower kind of depression here, thus causing weight in the hips in females to be slightly lower and also slightly wider than in males. This is actually going to allow us to have a larger pelvic opening. Okay. It's both a larger pelvic inlet and a larger pelvic outlet. Why do you think we need a larger pelvic inlet and outlet? Birth. Exactly. We have to fit a small human through this space. Okay. The ischial spines on females also have to point slightly further outside. That way we don't have these big two giant pokey bits pointing straight into the middle of that circle that we are trying to form. Because if you take a baby and you shove them through those two pokey bits, they're going to come out looking like Captain Worf from Star Trek. Those of you that aren't nerds like I am, that's the one with the big ridges down the sides of his head. Okay. Problematic if you are not that particular race of alien. Okay. We don't want that, because that would basically, like I said, kind of kill the fetus and also cause a hellacious pain for the mother in the process. Okay. So we want those things out of the way once again for the case of childbirth. However, in males, why don't we just have the same structure in males? Well, like, why are males different at all, even though they don't have to go through childbirth? Well, what benefit does basically being more vertical and slightly more sturdy get us while also being more narrow here? What this actually gets us is essentially more mechanical strength. Okay, by having them more vertical, this puts the muscles that are attached to these in slightly straighter lines, which means they can be a little bit stronger in general than the females. That's not to say that there aren't plenty of females who are way, way, way stronger than me. I'm pretty sure Serena Williams could kick my ass right now without having like 2 seconds of thought and without probably sweating a single drop. Okay. However, we are looking at kind of just our general themes here. Okay. Straighter lines means we get potential for more strength in the legs. Also heavier bones, once again, to help deal with both extra muscle strength while also helping deal with extra mass of the individual just in a whole. But once again, there is lots of intergradation between these two things. This is a continuum. It's not a, this is A, this is B. All right. Now, getting into the lower limbs, the first bone of the lower limbs we have is the femur. This thing is incredibly heavy. Now, let me go ahead and show you what a femur looks like when compared to a humerus. Humerus, femur. Something like 3 or 4 times the mass. Why? This one supports weight. This one supports a cell phone. Okay, that's the difference. Okay, this one you can use to throw a ball. This one you can use to stand on and crush the ball. Okay, that is the big difference between these. This one holds your weight. This one does not. Because of that, this one is so much heavier. The head, see how much deeper the head is? Why? Well, that's going to limit our motion, right? Like, it's going to be a lot harder to kind of do the splits with our legs than it would be to do this, essentially the splits with our arms. Everyone can probably raise their hands above their head and even go slightly past their head, right? Well, if you can do that, that is essentially the kind of the same thing. I dare to say you could not touch your shoulders with your legs by going out to the side, if I had to guess. Probably not. Not without causing some sort of weird contortion or strain or hurting yourself, or at least hurting me just by looking at you. Okay. We have very limited movement here. Okay. Why? Because we need the strength. We sacrifice the movement to gain extra strength. Okay. Because we need to be able to run and jump and things like that. We don't need to be able to do the same things with our legs as we can with our hands, because our legs are having to move us around all the time. Okay. Now, in the little divot in the head of the femur here, we have what's called the fovea capitis, or the fovea. This is basically going to be an attachment site for the ligament, what's called the ligament of the femur, which once again is going to give us extra strength. We also have a really deep interaction with the hip because of the size of the head here. If you've ever heard of someone having a hip replacement, they come in and they literally cut that off and they replace it, and like they bolt in with some titanium bolts and stuff like that and put on like a new one right here. And that, but then get stuck into essentially a facet of making inside the hip bone of that person as well. If you want to see a gruesome surgery on the internet, look up a hip replacement. It is gnarly. You also get to watch bones bleed, which is fun. I do weird things for fun. I'm not a normal person most of the time. Sometimes, I'm mostly normal. It's fine. All right, big heavy shaft of the bone down here. Then we take all that mass from the legs and we split it into the knee. Okay, we have to spread as much of that force out as we possibly can. So we're going to spread over as much surface area of articular surface as we can. To do this, we're going to be doing this in the lateral and medial epicondyles. How do we know which one is medial? Because it's the one that's under the head. So the head is always going to be medial here because your legs come out the sides of your hips, not out the middle. Okay, so because of that, the head of the femur has to face medially. Thus, track it down, that has to be the medial condyle. This would be the lateral condyle. The bumps above those are going to be epicondyles. Those are going to be important attachment sites for muscles. Then we have the patella, the kneecap. This is basically going to be stuck inside the tendon that connects our quadriceps femoris to the tibia, which is going to be underneath this bone. It's very, very important though, as that attachment site, and it needs to be able to glide up and down the anterior surface of the tibia. All right, now once we get below the knee, we're going to find the tibia and the fibula. The tibia is shaped like a T and starts with T, thus tibia. This is the fibula. Anyone want to guess which of these two is load bearing? Probably this one. Why? Because it's big and heavy. Like you could give somebody a concussion with this fairly easily. Okay. This one, not so much. That's because this one is basically just here as a support structure. It doesn't really do a whole lot. The tibia is the one that is going to be supporting your weight. Okay. So we have this big flat spot on the top of the tibia, which is where our knee is. So we can spread as much of that force out over as much surface area as we can. So we're going to get this nice interaction. This isn't actually the right tibia, but that's fine. We're going to get this nice interaction between the medial condyle of the femur with the medial condyle of the tibia. Now, the way we're going to tell the medial surface of the tibia is actually from this little guy right here, this little bony protrusion, okay? This is going to be called the medial malleolus, okay? Medial because it is on the medial surface of the bone. So I can now tell this is a left tibia because this one is right here. We know the top of the bone is up here. And this big arch, which you can feel. So if you feel your tibia or you feel your shin, that big sharp line on the front of your shin is right here. This is going to be called the anterior border or the crest of the tibia. You can actually feel that on the bone. We know that that has to face anteriorly. You'll notice you don't have one of those on the back. Okay. So that tells us that this is the direction this bone has to face. So this is up, this is the front, which means this part has to be the middle. So this then is a left. Like I could line this up with my left leg and everything would fit. This big bump though right here, this medial malleolus, is also going to be the big bump that you feel on the inside of your ankle. Okay, so the big bump that you feel on your inner ankle is actually going to be here, your medial malleolus. But when you feel on the outside of your ankle is this little flat bit right here on the fibula. Okay, so the fibula is basically, like I said, a support bone. It's going to sit on the back of the tibia just like this, where we get this nice little cage down here at the bottom for our ankle. This is going to help keep our ankle in place and keep it from being able to come out to the outside or come out to the inside. So basically it has to stay inside this little groove and basically should only move straight up and down. We like to try and do lots of stuff to make it do side to side stuff, but it doesn't really like that. And this is actually going to limit some of that motion so that we can maintain stability, maintain strength, rather than getting that extra mobility out of it. But even then, that is going to be at least a movable joint and often one of the more commonly dislocated or injured joints in the lower leg. Okay. All right, then we get into the tarsals. So the bones of the feet are basically the same as they were in the bones of the hand. So in this case, though, we're going to use the word tarsals instead of carpals. So the bones of the ankle are the tarsals. The bones of the fleshy bit of the foot are going to be the metatarsals. And then finally, the bones of the digits are the phalanges. Now we're going to order them or number them from medial to lateral, from big to small, just like we did in the hands. So in this case, the big toe is 1, then 2, and then so on as we move out. Now, I am only going to have you know 2 tarsals, just like I had you only know 2 carpals. The 2 tarsals we are going to learn are the talus and the calcaneus. The talus is going to articulate with the tibia. So T for talus articulates with T, the tibia. It's also on T, the top of the foot. Okay, so this is basically where you're going to transmit weight from your leg down to your foot and ankle. Now, the calcaneus then is your heel bone. Okay, so the calcaneus is your heel bone. The talus is the bone that is on the top of your foot. Those are the only 2 tarsals that you need to know. Then, like I said, we have the bones of the metatarsals, and then finally the bones of the digits, which are the phalanges. And just like in the hand, we have 3 phalanges: proximal, middle, and distal. In our digits, the same way we did in the fingers, it's the same way we did in the hand. And just like we had in the hand, our single large digit only has 2 bones. So we have proximal and distal phalanges in the thumb, or in this case, the big toe. Now, we do have arches to our feet. We actually have 3. We have a medial arch, a lateral arch, and then finally we have a transverse arch, which basically goes underneath the ball of your feet. Those 3 arches, though, are basically there to help support the weight of your body. Okay, basically, as you apply more weight, those are going to kind of flatten themselves out a little bit, but by maintaining a little bit of arch, they're going to maintain a little bit of strength. Imagine like an arch on like a bow or something like that. It's the arch of the structure that actually allows it to have strength and resist compression. Okay. Without that arch, you're not going to be able to resist compression very well. So if you know someone with flat feet or someone who has like taken out and flattened these arches out, oftentimes what that'll lead to is lots and lots of pain in both their musculature in their feet, but also in their legs and their back. And that's because all of that weight is now transitioning to the ground in a way that is not natural and is not really supported by the shape of the foot anymore. Whereas this way, we're able to transmit all those forces through the bones and the tendons and the muscles, and thus allow us to support all of that weight without causing pain. All right, any questions? No, I tried to talk as fast as I possibly could. I'll take 30 minutes for that any day. That's not bad. Okay, all right, so now use the rest of your time, which is around 30 minutes or so, and look at all these parts and pieces from the bone boxes. Just make sure they go back in the boxes where you found them. Everybody good? Yep. Online people, this would be a great time for you to do those anatomy and physiology revealed assignments.